Thank you for viewing this presentation entitled Demystifying the Abnormal 3-Vessel and 3-Vessel Tracheal View. The 3-Vessel and 3-Vessel Tracheal View is arguably the most essential component of the fetal cardiac exam, and this presentation will highlight the importance of this view in diagnosing abnormalities with the great arteries, including complex conotruncal malformations, ductal-dependent lesions, and branching abnormalities. Now, again, these views, the 3-vessel and 3-vessel tracheal views, are derived from the transverse fetal body planes. And specifically here, you can see that the cardiac long axis is derived from a slightly different angle than the fetal transverse body plane. And these views here on the left panel are the views that we will be obtaining from the 4-chamber view up to the outflow tracts. This is the 3-vessel view, and then this is the 3-vessel tracheal view. And so as you can see, the imaging planes through the heart are at different levels, and by sweeping more cephalad on the fetus and with slight angulations, you can obtain these views. Here is the 3-vessel view and the 3-vessel tracheal view, slightly different rotations and angles from each other in the top of the mediastinum. So how do you know when these views are abnormal? Well, some key things that you should keep in mind when you're seeing these views, the 3-vessel and 3-vessel tracheal view, based on pattern recognition, you should be able to see whether there are any discrepancies in the vessel sizes, any addition or absent vessels in these views, atypical position or course of the vessels, anytime you have abnormal connections or discontinuity of the vessels, either one of the vessels. Turbulent, continuous, or reverse flow is always abnormal in the chest. And remember that when you have reversed flow plus a vessel size discrepancy, you're likely to have a ductal-dependent lesion. So now this is a list of just a smattering of the things that you can see in this 3-vessel tracheal view that may be abnormal. There are more than this, but this is the main list of the most critical things that you can see, starting with right aortic arch and vascular rings. This is an example of a right arch with a left ductus. You can see the trachea in the middle there, and that is a vascular ring. Also, venous anomalies. Left SVC to the coronary sinus is one of the main venous anomalies that we can see, where we have 4 vessels instead of 3 at that upper chest view, the 3-vessel tracheal view. It end up being a 4-vessel tracheal view. Transposition of the great arteries, Truncus arteriosus, and pulmonary atresia with an absent main pulmonary artery and MAPCAs. Those are the 2 that you will see, just really a single great artery on either side, on either left or the right side of the trachea, and that's pretty obvious in this view. Interrupted aortic arch is discontinuity between the ductal and aortic arches. The aortic arch is typically interrupted and goes straight up into the upper chest and upper mediastinum. Coarctation of the aorta is another one where you see a vessel discrepancy, large ductus and small aorta. Hypoplastic left heart syndrome, same thing. You'll see reversal in the aortic arch. Tetralogy of Fallot and aortic stenosis and pulmonary stenosis can also be evaluated in this view. And most importantly, the ones highlighted in yellow, these are ductal-dependent lesions, and these can really only be diagnosed in this view. This is a very critical view to diagnose and to rule out whether any of these anomalies are going to be ductal-dependent lesions. Now, this is how we do these views. And so from the 4-chamber view, sweeping up more cephalad, we pass through the 3-vessel view. Here's the LV outflow tract, RV outflow tract, 3-vessel view, 3-vessel tracheal view there. And so as we sweep up into the mediastinum, we can actually see these views pass by, and we try to record this as one long sweep so that we can get all of this information into this clip. So now there is a difference between the 3-vessel tracheal view and the 3-vessel view. Here, the 3-vessel view on the left side, we can see that there is a bifurcation of the pulmonary arteries here, SVC, aorta, and main pulmonary artery. And this doesn't quite show the whole airway. We're seeing the bronchi here. Here's the right bronchus. This is part of the carina where the right bronchus meets and then transitions to the left bronchus. And so this isn't really the trachea, but you can see all three vessels in their normal position. And you have the pulmonary artery most anterior here in this view. You can even see some of the thymus gland in front of the vessels there. Now here on the right side, you can see at the end of that sweep that there's a V forming for this three-vessel tracheal view. There's the trachea, again, SVC, aorta, and pulmonary artery, and this is a normal appearing three-vessel tracheal view. So what's important about this view is that we can see the position of these arteries in this three-vessel view, and we can see that the pulmonary artery, again, is most anterior in the chest, where you have the SVC here on the right, the aorta is next, is on the right of the pulmonary artery, but next to the SVC, and then the pulmonary artery, again, is more anterior, slightly bigger main pulmonary artery than the aorta in a normal situation. And over here on the right panel, you can see as an example for detransposition of the great arteries that there is an anterior positioned aorta. And so SVC on the right, aorta is next to the SVC, it's on the right as well. And then you have the main pulmonary artery with PA branches here on the left, and the aorta is again more anterior than the pulmonary artery in this type of transposition. D transposition and L transposition are pretty much the same in the sense that they have the parallel appearance in the four-chamber and outflow tract views, but up in the upper chest you can see that the aorta is mostly anterior in both of these types. And so you can see for D transposition, the same exact case that I showed on the previous slides, that the aorta is anterior and rightward. In this case, you have, again, a cephalic lie in both of these fetuses, but the aorta is more anterior and leftward of the pulmonary artery here, the most leftward vessel. And so you're seeing the three-vessel view with the SVC, the pulmonary artery with the PA branches, and then the aorta more leftward. So when performing this view, and you can see the three-vessel tracheal view here, we have to identify where the trachea is, and then we're going to pull this image apart from that illustration, and we can see that the trachea is now the center of the chest. And so that's the center landmark within the chest. And now we'll divide the chest, and then that will allow us to divide the chest into left and right parts. And that way we can see what is on the left of the trachea and what is on the right of the trachea. Now, in a normal case, we will have this three-vessel tracheal view where the aortic and ductal arches form a V, again, on the left side of the trachea. You have the SVC, aorta, and ductal arch. And it's shown here in this cephalic presenting fetus, this diagram. Color Doppler evaluation of this view, this three-vessel tracheal view, should show antegrade flow through both the aortic arch and the ductal arch, and it's not uncommon that we see slightly more accelerated blood flow through the ductal arch as there is more volume passing through the right side of the heart, so this is a normal finding, specifically in late gestation as well. Now this is also a normal three-vessel tracheal view. It may not look normal, but you have anterior here. This is the front of the fetus. This is the spine. And so this is the left back of the baby. This is actually the left side. And this is the right side. And so here you're seeing the trachea. Again, this is SVC right in front of the trachea there. But the transverse aortic arch is right here. You can see there. And then you see the main pulmonary artery here, and you see the duct, and it takes this tortuous course, but it's on the left side of the trachea, and it comes back to the aorta. Although a little bit tortuous, it still is on the left side of the trachea. And so this is what we would call a normal variant, where we have antegrade flow through the aortic arch, antegrade flow through the ductal arch, but it takes this slightly tortuous course here and comes back into the descending aorta there. Now, one must evaluate this flow velocity through the duct in these tortuous curves just to make sure that there's not accelerated or obstructed flow through these curves in the ductal arch. Another case here, we have another tortuous duct. Here's the MPA, and then this is a cephalic presenting fetus, but this is the spine here. The front of the fetus is here, so this is right over here. This is left. We have levocardia. Here is the main pulmonary artery, and you can see just how tortuous this duct is right here. It takes this curve, two acute curves here, and then comes back to the descending aorta. There's the transverse aortic arch, and right here is the trachea. And so both the aortic arch and the ductal arch, although very tortuous, are to the left of the trachea. And so when you see with color Doppler, there's a little bit of flow acceleration around these bends, but nothing is obstructed. We have slightly accelerated but non-obstructed blood flow through there, and we can see that it is indeed a left-sided duct and a left-sided aortic arch, not a vascular ring, and so this would be considered an atypical but normal variant. And so this is the most common congenital heart defect, quote unquote, that we see is an additional vessel in the three-vessel tracheal view. This is the fourth vessel, and it is the persistent left SVC to the coronary sinus or to the atrium, for that matter. We've seen those cases as well. But you can see here that red circle highlights a left SVC, which will give you that four-vessel view in the upper thorax. And so when you were looking at this three-vessel tracheal view from this four-chamber view, you can clearly see the V of the three-vessel tracheal view, and it is to the left of the trachea. Here is the trachea there, SVC, aorta, and pulmonary artery, and there's the fourth vessel here at the end of that sweep. You'll see right there is the left SVC. Better view of this, higher up in the chest, you can see bilaterally we have a right SVC over here, a left SVC over here, and there is no bridging vein. And when you apply color Doppler, you can see that the V of the three-vessel tracheal view is to that left side of the trachea, and then you see color Doppler in both of those superior vena cava. There's even a little bit of a shot of this aberrant right subclavian artery here. You can see that in that red signal there is an aberrant right subclavian artery traveling behind the trachea and esophagus. And a closer up shot of that with low scale color Doppler shows that left SVC with flow in it and no bridging vein there. Great case. This is another case of an abnormal appearing vessel, fourth vessel in the upper chest. Here we can see from that four-chamber view, outflow tracts. This is the spine. We're seeing four vessels here. So again, levocardia, left side over here. There's left vessel, PA, aorta, and the right SVC is over here. One more time, there's the right SVC. Three-vessel tracheal view is normally on the left side of the trachea, nicely shown at the end of this sweep. And so this additional vessel is in the position of where we would see a left SVC. And as we look a little closer at that vessel, we can see that there is a bridging innominate vein, which is an unusual appearance when we have bilateral superior vena cava. You typically don't have a bridging innominate vein, and usually if you do have one, it's not that big. And so this is quite enlarged bridging innominate vein. So we apply color Doppler. This is actually at the level of the four-chamber view, sweeping up to the upper chest. And in the beginning of the sweep, you see a red signal flowing into this vessel and then flowing up and then down to the right. So from left up above the vessels to the right SVC, this is actually a case of total anomalous pulmonary venous drainage, supracardiac type, where you have a pulmonary vein confluence behind the left atrium, which drains to this left-sided ascending vein that then drains to the innominate vein and drains to the SVC. And so that's a great pickup in this view if you can see this. So the other most common thing that we see is an aberrant right subclavian artery where you have a normal left arch and left ductal arch, but then as you saw in that last case prior to the total veins case, you can see that how that aberrant right subclavian artery travels in this angle behind the trachea and esophagus, and the trick is to get this aligned in a way where you can have that color signal flowing almost in plane with the plane of insonation. Will give you the best view of that. And so we start out again with the four-chamber view. This is a breech presenting fetus, and so this is a left-sided levocardia, left-sided apex. This is the left side here. This is the right posterior with the spine. There's the aorta. So as we sweep more cephalad, we end up with the three-vessel tracheal view in a normal configuration. To the left of the trachea, here's the trachea, SVC, aorta, and pulmonary artery. And once we apply color Doppler, you can see this aberrant subclavian running behind the trachea off to the right shoulder. And so this is classic alignment for that to evaluate the flow pattern, in that it is an arterial flow pattern, and we will see that it matches the flow within the ductal and aortic arch as a systolic signal. Now onto vascular rings. This is a right arch left ductus arteriosus subtype of vascular ring, where we have the U sign. And so here we see that the aorta is to the right of the trachea, and you have a posterior coursing ductus arteriosus. And then I've added in this aberrant left subclavian artery that we typically see with this subtype of right arch left ductus, and then the pulmonary arteries here are seen in the distance. But this is classic U sign that we see in this view, and you'll see that with the color Doppler. As we always start out with the four-chamber view, this is a cephalic presenting fetus, and here we can see at the end of the sweep that U sign. A better look at this, a more close-up view, there is the U. And so just like that diagram that I just showed you prior to these slides, you can see that there is the SVC, here's the right-sided aorta, in the middle is the trachea here, there is the ductal arch, main pulmonary artery there with the branches, and that is a left-sided ductus arteriosus that courses behind the trachea here. Now with color Doppler, it's better defined, where you have this U sign with color. You're seeing a little bit of that right pulmonary artery in front of the trachea there, or in front of the airway, that looks like when you see a double aortic arch, and you'll see that in the next couple of slides where you have flow in front of the trachea, but in this case this is the dominant vessel. So if this were a double arch, you would see a little bit of a red signal in front of that trachea, and that's key. So as I stated, this is double aortic arch. It looks a lot like right arch left ductus, where you have this U sign, but you actually have a vessel or an arch that runs in front of the trachea. And so whether it's a right arch dominant or a left arch dominant, you're going to have one of the arches run right in front of the trachea and form this O. And so we'll call this the O sign, where you have flow all the way around the trachea and esophagus here. Again, four-chamber view, this is a breech presenting fetus. And we can see that this is left and that's right over there. There's the innominate vein, and you're seeing this aorta is a right-sided aorta. So this is right over here. This is the right-sided SVC. The innominate vein is draining toward that right SVC and this upper chest. But the reason why we're this high is you can see that smaller vessel that transitions in front of the trachea here and then starts to curve backward. And this is actually a hypoplastic left-sided aortic arch in this double aortic arch subtype of vascular ring. And the very end of that, you start to see the MPA here, right here, and then the ductal arch on that side. It is, again, it is a left-sided ductal arch in this case. Now with color Doppler, we can better define the fact that this is the O sign. You have color all the way around this trachea and esophagus. And again, this red signal here is that ductus arteriosus. It is a left-sided ductus arteriosus. But you see the flow all the way around the front of the trachea through this small left-sided aortic arch. and a dominant right-sided aortic arch, double aortic arch. Now this is also a double aortic arch, but at the end of this sweep you see a cephalic presenting fetus, and we're seeing levocardia, so this is left and that's right, but you see this V form, and this is a typical appearing three-vessel tracheal view at the end of the sweep with a V. But when you turn your attention to what's on the other side of the trachea, this is a systolic flow signal, and you're seeing the dominant looking larger left-sided aortic arch and a smaller right-sided aortic arch, which is very atypical. We don't typically see this configuration. We typically see a dominant right aortic arch, but this is an example of a smaller but continuous right-sided aortic arch. And so you have this circle, this O sign around the trachea with a dominant left-sided aortic arch. And again, a left ductus arteriosus. Better look at that. You can see that there is bidirectional flow in this right-sided aortic arch, which is not uncommon. When you have a hypoplastic arch, you'll have, in many cases, bidirectional or reversed flow in that smaller arch. And so in this case, we have a smaller right arch, a dominant left arch. So right aortic arch with mirror image branching is not a vascular ring in these cases where you have an anterior left-sided ductus arteriosus coming off of this left innominate artery. And so we've shown that here, and this is most common with tetralogy of Fallot, either with antegrade perforate pulmonary valve or with pulmonary atresia. You can see this configuration with a right aortic arch and mirror image branching and a left anterior ductus arteriosus as shown here. Again, not a vascular ring. As we sweep more cephalad, you can see that this is a right-sided aortic arch. And you can see the fetus is having some hiccups there, but levocardia in this breech, it's transverse head left, which we treat as a breech. It has the same appearance in this four-chamber view as a breech-presenting fetus. But you can see at the end of that there's the trachea right in here. There's trachea. And this is transverse aortic arch here, right there, and there's SVC. So right aortic arch, and we're going to look to see, is there something going behind the trachea? Is there a ductal structure going behind the trachea? This is RVOT, little small pulmonary valve there. This is a tetralogy of Fallot case, and we're seeing the trachea really clearly here. And as we apply color Doppler, this is the innominate vein here, flowing up on the screen toward that right SVC. There's the right aortic arch there. Again, trachea is here, and we're seeing the innominate artery, which is a mirror image left innominate artery. We have both the left carotid and left subclavian coming off of that vessel, but you're seeing a little reversal of flow, a little flicker of flow there, and that is the ductus arteriosus. This ductus arteriosus is an anterior left ductus arteriosus that has a bidirectional flow signal, and this is with tetralogy of Fallot, so we would be concerned that there may be some ductal dependence of this postnatally because of that reversal of flow. But that is an example of a right arch with mirror image branching and a left anterior ductus arteriosus, not a vascular ring type. Better look at that. Here you can see that continuous flow signal right there in that ductus arteriosus that inserts near the base of the LPA there. That's the LPA at the end of that sweep. So how about a small aorta and a larger ductus arteriosus and main pulmonary artery? And so we see this in coarctation of the aorta or hypoplastic left heart syndrome. And with hypoplastic left heart syndrome, classic hypoplastic left heart syndrome, you'll see fully systolic retrograde flow in that transverse aortic arch and even into the ascending aorta. With coarctation, sometimes you'll see some bidirectional flow. You may see antegrade continuous flow in this vessel, but I've thrown in this red signal here just to show that occasionally you will see some reversal in the distal arch. And this is basically how we would measure the diameter of these vessels to see the vessel size discrepancy in these cases with hypoplastic left heart syndrome or coarctation of the aorta. Typical four-chamber view and a significant narrowing of the aortic arch and coarctation of the aorta. Here's the apex forming left ventricle that's kind of dwarfed and smashed by this RV here. And we can see in this three-vessel tracheal view, there's the larger pulmonary artery, the ductal arch here. Transverse aortic arch is quite small, and if you compare these vessels, it's really less than a quarter of the size of the main pulmonary artery, even smaller than that. Up in the upper chest, you can see the branching pattern is a typical branching pattern of the aorta. And with color Doppler, at the end of the sweep, you see the innominate vein is a normal size and it drains normally to the SVC here. And with color Doppler, we can see antegrade flow through that ductus arteriosus here and a little bit of flow reversal in that transverse aortic arch there. Mostly antegrade flow, but there is a red flow signal there in the transverse arch, which is not uncommon with significant to severe coarctation of the aorta. There is your flow signal with pulse wave Doppler. We can see antegrade flow and early systole, late systolic retrograde flow, and then the diastolic flow pattern that you have that is antegrade flow and late diastole. Another case that is not the same as the previous one, this one actually has total anomalous pulmonary venous drainage. I wanted to throw this in there because this is another case that has coarctation of the aorta. We're seeing also a persistent left SVC to a dilated coronary sinus here. Smaller left ventricle, left side of the heart. Right side is quite enlarged. Again, levocardia. And we can get a better chance of seeing just the discrepancy in size in those vessels and what's going on up north and the upper mediastinum, with the aorta being about a third of the size of the main pulmonary artery there at the end of that sweep. Both arches are to the left of the trachea there, but we're seeing something a little extra here in that view. At the end of that sweep, you see a little bit of extra cystic structures. Again, we see that left SVC coming up, so there's a four-vessel view here, but there's something extra there. And so we'll turn the color on, we'll evaluate what the flow pattern is in the ductus and aortic arches there. Again, they're left of the trachea, that's the trachea there. And then as we pan a little bit closer to the other structure that we were seeing, we see some continuous flow in that upper chest. Remember, this is never normal. This flow is coming from a vertical egressing vein. Again, this fetus has total anomalous pulmonary venous drainage type 1, which is supracardiac, and it drains to that right-sided SVC obstructed. Now this vein, the gradient in this vein is quite elevated. We can see that it's already 6 millimeters of mercury in the fetus, and so postnatally it's going to be even more than that. And this fetus may be in pretty dire straits postnatally. This case is a case of hypoplastic left heart syndrome. Again, the LV is not contracting very well, and it is hypoplastic, does not meet the apex. And so you see here some endocardial fibroelastosis of the LV. And when you look at the upper chest view, and so the three-vessel tracheal view, we're transitioning to, this is the MPA here. You see part of the RPA there, and so this is left, this is right. And we're seeing this tortuous looking larger ductus coming around. And as we look at the three-vessel tracheal view here, we start to see there's a better view of that. This is the trachea here, right there. The SVC is over here. So it's kind of an oblique view, but we're seeing the ductus arteriosus and the aortic arch, which is this smaller vessel here to the left of the trachea. And when we apply color Doppler, we can see systolic retrograde flow through the aortic arch in this case of hypoplastic left heart syndrome. Spectral Doppler of this transverse aortic arch confirms that there is systolic retrograde flow in that transverse arch. Now with tetralogy of Fallot, the aorta will be the dominant vessel. The pulmonary artery, main pulmonary artery and branches will be some degree smaller than the aorta, and the ductus, wherever it originates from, if there is reversal of flow, shown here in red, then that points to the fact that this may be a ductal-dependent subtype of tetralogy of Fallot. So we start out in the axial four-chamber view here. We're seeing a single outlet. This is the aorta, and there's a large subaortic VSD. We call this an anterior malalignment VSD because there is aortic override of that VSD. And as you transition forward to the upper chest, three-vessel tracheal view, you start to see the SVC, the aorta here, and you can see part of the main and branch pulmonary arteries here. There's the trachea. So it looks like this aortic arch goes to the right of the trachea. There's a better look at how small that main pulmonary artery and pulmonary valve are in comparison to the ascending aorta. Again, this is the SVC, and this is part of the bronchi here. This is the right bronchus, this is the left, and you're starting to see where the descending aorta is. So this is a right-sided aortic arch. Now, as we transition up higher than this, just past the main pulmonary artery and branches, you see this sort of tortuous structure here. And what you're going to see is that part of this is the airway, this here, but this is the ductus arteriosus. And we'll add color to this. Now, as you see, this is the right-sided aortic arch, this blue alias signal here, just to the right side of the trachea. But importantly, you see this red signal, reversal of flow in the ductus. This is a right-sided ductus arteriosus. So right aortic arch, right-sided ductus arteriosus in Tetralogy of Fallot. And this type of right arch, right ductus is not a vascular ring, but there is reversal of flow in that ductus arteriosus, which makes this likely postnatal ductal dependence of Tetralogy of Fallot. Very important to mention that Tetralogy of Fallot can come with other abnormalities, one of which is discontinuous pulmonary arteries. And in this case, we can see four-chamber view, slightly oblique four-chamber view, but you can see a large VSD with aortic override crossing pulmonary artery here, smaller pulmonary artery. And you're already seeing here from this underside of the lesser curvature or deep proximal descending aorta, you see a ductus arteriosus that connects the main pulmonary artery with the aorta here. And so we're going to move to a color picture in the axial view here. We're seeing that it is a right-sided aortic arch. If you keep your eye on the trachea here, right-sided aortic arch. At the end of that, you're seeing the main pulmonary artery and the RPA. There's the innominate vein draining into the SVC. So we have a good picture of what's going on in the upper chest. And you're seeing antegrade flow in this color Doppler picture through the MPA and RPA. And the LPA here, you're starting to see is in a slightly odd angle. And then there's this little bit of a flicker here. This is actually a right aortic arch with mirror image branching. You see that first vessel coming off and going there that way to the left upper chest, sort of laterally through the chest. And so that's the left subclavian artery right there. If you keep your eye trained right in that spot where the blue dot is, that is actually where the ductus arteriosus comes off. And if you look closely, the left pulmonary artery arises from that ductus arteriosus. And so this is a discontinuous left pulmonary artery from a left ductus arteriosus. And what's important is there are bilateral ductus arteriosi. So there's a right-sided ductus arteriosus that originates from the aorta and connects to the main pulmonary artery right at the base of the RPA here. And then there's another ductus, left anterior ductus, connecting from that innominate artery to that left pulmonary artery there. And this is not a vascular ring type. We have bilateral ductus arteriosi, Tetralogy of Fallot with discontinuous pulmonary arteries. Now, when you're seeing a single great artery in this three-vessel tracheal view, you should be thinking probable truncus arteriosus or pulmonary atresia with multiple aortopulmonary collateral arteries. In this case, we're showing both. Here is a right-sided aorta, which can happen in these types of defects. So right-sided aorta, and this is actually a type 1 truncus arteriosus shown here, where you have the pulmonary artery branches off of a small main pulmonary artery segment that comes from the ascending aorta. But importantly, at this level, you're not seeing two vessels. You're not even seeing these branches. You're seeing a single artery next to the SVC, and here's the trachea. So these are multiple pulmonary arteries collateral vessels coming off the descending aorta, and that would be in the type of tetralogy of Fallot, severe tetralogy of Fallot, where you have pulmonary atresia. You can have discontinuous PAs with truncus arteriosus, so anytime there's a pulmonary artery, some kind of a pulmonary artery segment coming off of the ascending aorta, a single unilateral pulmonary artery, and a missing, the contralateral pulmonary artery is missing, be looking for discontinuous PAs and the origin of that pulmonary artery coming from somewhere else, maybe the descending aorta or somewhere from one of the branching upper chest arteries, the innominate artery, subclavian arteries. We can see that as well. Now, this is truncus arteriosus type 1. Here already in this 4-chamber view, levocardia, you're already seeing large outlet VSD, a dysplastic truncal valve here. Here's the ascending trunk. Again, this is left levocardia, this is right. And so as we go to the 3-vessel tracheal view, nice axial view here, one rib on either side, SVC here, the aorta here, transverse aorta is just to the right of the trachea, so there's trachea. But importantly, you're seeing an early bifurcation of that trunk. You're seeing the main pulmonary artery segment there and the PA branch bifurcation here. So this is type 1 truncus arteriosus. Color Doppler really nicely highlights that. Again, this is a right-sided aortic arch. It looks like there may be an aberrant subclavian here. You start to see right there. And so this is right-sided aortic arch with probable aberrant left subclavian artery. Truncus arteriosus type 2, same view here, levocardia. This is left and this is right. We're already seeing a single outlet here, truncal valve there, large outlet VSD, and you're starting to see bifurcation here early, right in here, pulmonary artery branches. There is no main pulmonary artery segment. These pulmonary branches come right off the trunk. Again, truncal valve here, slightly dysplastic, very dilated ascending aorta here beyond those pulmonary artery branches. And in this straight axial view here, sort of a 3-vessel view, where you're seeing SVC, here's the truncal root, pulmonary artery branches, they come off the same area, but they actually appear to cross a little bit in this view. Here's the descending aorta. A little better look at that, and you're going to see sort of ascending here. This is a left-sided aorta, but just look how dilated that ascending aorta is here next to the SVC. There's the trachea right here at the end. Trachea right there. Okay. Truncus arteriosus type 4A is truncus with interrupted aortic arch. Here, levocardia. This is left. This is right. Posterior here. And we're seeing a single vessel. This is the truncus arteriosus, the truncal outlet here, mostly from the right ventricle again, large outlet VSD. And as we sweep up into the upper mediastinum, you can see early bifurcation, really trifurcation of that truncal root. You're seeing pulmonary artery here, descending aorta, transverse aorta here, right here. This is actually the ductal arch, because in this type of truncus arteriosus where you have interrupted aortic arch, you're seeing SVC ascending aorta here. This is the ductal arch. It's a type B interruption where you have ascending aorta, which gives rise to the right brachiocephalic artery and the left carotid, and then the interruption is between the left carotid and the left subclavian artery in this case, since it is a left-sided aortic or ductal arch here. The aortic arch is interrupted, and you can see early the PA branches come off continuous from a main pulmonary artery segment, so interrupted aortic arch type B with type 1 truncus arteriosus. Color Doppler confirms that, and you actually have an aberrant subclavian here, so you have a left arch with an aberrant right subclavian artery, and so that first vessel that comes off gives rise to the right carotid. The left carotid, the left subclavian also comes off here, and then the right subclavian is aberrant there. So type B with an aberrant right subclavian artery. Now, tetralogy of Fallot, or pulmonary atresia with multiple aortopulmonary collateral arteries, will look very similar to Truncus arteriosus. You have a single outlet here. There's a large anterior malalignment VSD or outlet VSD, and this is a slightly oblique angle, but you're having levocardia here with left ventricle, right ventricle, anterior. So now, when we start to apply color Doppler, we can see that the aorta in this three-vessel tracheal view and the upper chest ascends on the right and comes across to the front. Here's the trachea here, comes across the front of the trachea and passes leftward. So it is a left-sided aortic arch. But importantly, you're seeing multiple other vessels coming off the descending aorta here. If you watch closely, you have this red vessel coming off and going into the right lung there, and then something else here. And so as you interrogate further with color Doppler, here's that posterior artery coming off the proximal descending aorta here in the back and coursing out into the right lung. And as we transition around to the left side of the fetus, we can see a larger artery here coming off the descending aorta and coursing into the left lung. And so that's a left MAPCA. We're not seeing a main pulmonary artery segment. We're just seeing a single vessel coming off of the left ventricle, essentially the aorta, the aortic outflow. And so as we continue to interrogate, we're seeing another large MAPCA, large collateral artery coming off the descending aorta, proximal to that other collateral that we saw going into the left lung. This large collateral goes off into the right lung. And so these are two main aortopulmonary collaterals coming off the proximal descending aorta at a level right behind the left atrium here. Pretty clearly shown with that color Doppler. Now, when you have a small ascending aorta with discontinuity and a lack of a three-vessel tracheal view V, as is normal, we see normally, then you should suspect the interrupted aortic arch of any type. And so when you sweep up to the upper mediastinum and you see the aorta smaller than even the SVC, usually in most cases in interrupted aortic arch, you'll have a smaller aorta, ascending aorta than even the SVC. You should suspect interrupted aortic arch. And so four-chamber view, levocardia, here's left, here's right, there's posterior. And right away, we're seeing a large subarterial VSD here. And as we look a little closer, the left ventricular outflow tract looks very narrow. Aortic valve there, small ascending aorta. Again, this is like a posterior malalignment VSD where you have a little bit of subaortic conus, slightly deviated posteriorly. And as we sweep up into the upper chest, you see that the ductal arch here is to the left of the trachea, and that aorta here is much smaller than it should be, even smaller than the SVC here. And as we look with color Doppler, we're not seeing the V that we typically see in the three-vessel tracheal view. This aorta does not meet the ductal arch back here, and you can even see the branching in the upper chest, which is a normal branching pattern. This is a type B interrupted aortic arch. Now, to confirm that, we want to turn to the sagittal view, and this is a very important view to confirm the discontinuity between the ascending aorta and the descending aorta here. There, you're even seeing the left subclavian artery, the last vessel of the branching pattern coming off the descending aorta here, and there is not a transverse aortic arch there. So, type B interruption of the aortic arch. Left pulmonary artery sling is quite rare, but we can see it pretty clearly in the three-vessel tracheal view when you're looking at the great arteries and you're seeing a really strange branching pattern. In this case, we have a normal three-vessel tracheal view, not uncommon, this V, but importantly, you'll see the anomalous origin of the left pulmonary artery from the distal right pulmonary artery here, and the left pulmonary will course behind to the right of the trachea and behind the trachea, in between the trachea and the esophagus, and then out to the left lung. And so in this example, we have a 4-chamber view. This is left and this is right. It's slightly oblique, but when we transition into the upper chest, we're starting to see this is the pulmonary artery here, and this is the ascending aorta. This is part of the SVC. Here's descending aorta, and so this is going to be the course of the aorta. But importantly, you're seeing the trachea here. This is the RPA as it goes out to the right lung. And this is the proximal LPA as it comes off of the RPA. There's the trachea, and so it comes to the right of the trachea, around, and goes out to the left lung. And as we see this, as we transition up, this is actually the ductal arch here that runs to the left of the trachea. Again, in the beginning of that sweep, you're starting to see the LPA right there, ductal arch on the left of the trachea, and so the ring is, this is the trachea, and so this is the ring here. And the pulmonary artery sling can cause severe compression of the trachea, severe airway obstruction. In most cases, you have complete tracheal rings, and which needs to be can be an emergency postnatally. The airway can be quite compromised. So just to highlight the most important parts of evaluating the 3-vessel tracheal view, you want to make sure that you obtain proper axial views. This is critically important. If you don't have one rib on either side and you're not straight axial, you could be misinterpreting the vessel branching patterns, the sidedness of structures, and so that's very important. You want to start at the 4-chamber view and sweep cephalad gradually and watch the course of the vessels and the branching of these arteries. Use the trachea as the central landmark. That's very important because it is the center of the chest, the center of space within the mediastinum. You want to recognize abnormal arrangement, sizes, and flows through the arteries. Vessel size discrepancy, when you see that, specifically if you have reversal of either of the blood flow in the vessels, whether it's the aorta or the ductal arch, it's likely ductal dependent, the lesion that you're dealing with. And beware of abnormal flows, whether they're continuous, turbulent, and again, retrograde flow in either of the arches is abnormal. Thank you so much for viewing the presentation.